Hello. So, obstructive sleep apnea. What is obstructive sleep apnea? It's a disorder which is characterized by obstructive apnea, hypopnea, and sleep-related arousals due to repeated collapse of upper airway during sleep. And this disorder is gradually increasing in our general population as the incidence of obesity or prevalence of obesity is increasing in our general population. The association of OSA is also increasing. So when you receive a patient for anesthesia, there would be a large percentage of patient with a suspected OSA or a diagnosed OSA. And compared to general population, the respiratory risk of complication, the cardiovascular risk of the cardiovascular complication is more in these patients. But there are strategies, there are ways by which we can optimize these patients and we can minimize those risks. In this section, we will talk about all those things. We will talk about everything that we need to know about for a patient with suspected OSA or with a diagnosed OSA when they are coming for surgery and anesthesia. So we will discuss about their preoperative assessment, their intraoperative management and their postoperative management. So let us start our discussion with the definition of OSA. So as I already said, OSA is a disorder which is characterized by obstructive apnea, hypopnea and or sleep-related arousals due to repetitive collapse of upper airway during sleep. So, obstructive sleep apnea is characterized by obstructive apneas, hypopnea and or respiratory effort related arousals caused by repeated collapse of upper airway during sleep. Now, as I said, the prevalence is increasing in our general population and it will continue to increase as with increase in incidence of obesity in our general population. So, the prevalence is gradually increasing as the increase in obesity is happening. Now, OSA increases the risk of morbidity and mortality. Morbidity and mortality, right? So, we need to have a prior diagnosis of OSA, or if patient already has a OSA, we need to optimize the patient prior to taking the patient for surgery. We need to know what are the therapies the patient is on. Now, ISD, that is International Classification of Disease Nomenclature, ISD 9 codes has shown the prevalence of OSA from 6 to 17%, but it can be higher in at-risk population. So, the various studies have shown that the incidence and the prevalence can be higher as 68 to 70% in high-risk population. And obviously, one high risk associated with OSA, I am mentioning repeatedly, obesity, right? So, incidence can be pretty higher in high-risk population. So, there would be a high chance you will receive a patient with a suspected or a known case of OSA. So, what are the perioperative complications that we are concerned with in a patient with OSA? As I said, compared to general population, the complication is more, the risk of complication is more in these patients. So, they have 2 to 4-fold higher risk of complication. So, patient with obstructive sleep apnea has 2 to 4-fold higher risk of perioperative complication, peri-op complication. And complications, the highest systemic complication associated with OSA is respiratory, followed by cardiovascular and some other. So, the most common complication, the most common system is respiratory, followed by cardiac complications in these patients, and some more complications like difficult airway or post-op delirium, post-operative delirium, etc. So, we will discuss about in detail what are the exact complications which can happen in these patients and which we have to look for. So, risk factors for increase in perioperative complications are related to the type of surgery these patients are subjected to. So, if they are subjected to the major surgery, which requires a prolonged general anesthesia, or if they are subjected to surgeries related to airway, or if they are subjected to general anesthesia with some more associated risk factors in them, then definitely the higher would be the risk in these patients. So as I said, the risk factors for perioperative complication, the risk factors for periop complication. The first thing it depends upon is type of surgery. So if the surgery is major surgery, or if the surgery is related to airway surgery, or if the surgery under GA, any surgery under GA with multiple risk factors already present in the patient. So what are those multiple risk factors which predispose any patient with OSA going for general anesthesia with a higher incidence of risk? So the factors which contributing to acute perioperative aggravation of obstructive sleep apnea, the present influence of anesthetics, sedatives and analgesics on central respiratory drive and on the airway protective reflexes and arousal response. So whenever we are giving our patient, OSA patient, even for a short general anesthesia or only for sedation, our sedative and hypnotic drugs, then both of them synergistically can increase the risk of complication in these patients. Then intraluminal upper airway narrowing due to post-endotracheal intubation edema. So if there is a traumatic intubation or even if there is a normal intubation, when we extubate the patient, there is a slight risk of let's say tracheal edema in the patients. That would again increase the risk of obstruction, especially in these patients, right? Then use of nasal packing, nasal tube, hematoma. Then forced supine positioning, right? Forced supine positioning or prolonged supine positioning can increase the airway edema. Then sleep deprivation, association of sleep deprivation. A lot of patients who are very anxious coming for even for a short procedure, for a let's say low risk surgery, because of sleep deprivation, the risk of, associated risk in patient would definitely increase. Then intense rapid eye REM rebound movement. Now all this contributes in the risk of aggravating the OSA. Temporary suspension of CPAP therapy due to pain. Now these patients, the OSA, diagnosed case of OSA patient, they are on CPAP, the positive airway pressure therapy. Due to some reason, due to many reasons, there could be a temporary cessation of these therapies. All this would lead to aggravation of OSA in these patients. Then the intro of fluids which we have given to the patient. Sometimes the rostral fluid shift causes neck edema and can also contribute in the obstruction. So any surgery, not only the major surgery or the airway surgery, any surgery under general anesthesia, they have factors which would contribute in aggravating the OSA. And as I already said, in patient with OSA, the risk of respiratory complication, cardiac complication is 2 to 4 times increased than general population, right? Okay, so the second let's say second thing which would tell us about the risk of, increasing the risk of OSA in the patient is severity of OSA. Whether the patient has a severe OSA or a mild OSA. So patient with more severe OSA definitely would have a higher risk. But saying this statement, I would again state that a lot of studies have shown a contrary result also. Shown that there is no increase in the risk of complications depending upon the severity of OSA, if proper perioperative strategies are practiced in optimizing these patients and minimizing the complication in these patients, then the severity of OSA does not increase the risk. So, but here I am writing that more severe OSA, higher is the risk. But as I said, lot of studies have shown the contrary, that severity as such does not increase the risk of complication if we practice proper strategies to minimize the risk. The newly diagnosed case of OSA, they increase the risk of complications, right? But even if we start in immediate and pre-op period, the therapies of OSA, then also the newly diagnosed case of OSA, the risk of complications are more. So, newly diagnosed OSA. Then use of, if we need to give our patient post-op opioids for pain management, then definitely the risk would be higher. So, requirement of post-op opioids, post-operative opioids. Then if patient has let's say comorbidities related to OSA present in them. If patient has multiple comorbidities, more the comorbidities, more higher would be the risk, and OSA can be associated with so many comorbidities which I will discuss. So, patient associated OSA with OSA related comorbidity, OSA related comorbidity like obesity, severe hypertension, then pulmonary hypertension, then coronary artery disease, then heart failure. If patient is associated with any of these comorbidity, definitely the risk would be higher. Then obstructive obesity hypoventilation syndrome. If patient is associated with obesity hypoventilation syndrome, right? In this, the patient's PaCO2 is more than 45 mm of Hg on even in awake condition. So, PaCO2 is more than 45 mm of Hg even in awake condition. This is obesity hypoventilation syndrome. And if patient has obesity, OSA overlap syndrome, that is OSA present with COPD. So, these are the terms that you need to be aware of. So, OSA overlap, syndrome. In this, patient will have COPD with OSA, right? So, all this would increase the chances of risk in these patients. So, what exactly are the complications which we expect in a patient with obstructive sleep apnea? As I said, respiratory complication, highest incidence. So, first I would talk about the respiratory complications. Okay. Now, patient of OSA in post-op, they can present with acute respiratory failure requiring non-invasive ventilation. So, first and foremost, the risk of acute respiratory failure is in them because of the contributing effect of anesthesia and its drug. So, acute respiratory failure, they have a risk of developing acute respiratory failure, and this may require management in ICU with non-invasive ventilation. Then post-op pulmonary edema, post-operative pulmonary edema, negative pressure pulmonary edema may be associated in them because they may try to breathe against the obstructed airway, because again condition and the anesthesia both can increase the risk of narrowing of the airway. Then ARDS, the association of ARDS has been seen in these patients. Then multiple episodes of desaturations and hypoxia. So, episodes of desaturation, right? Then worsening of OSA, worsening of their present condition. So, worsening of OSA if patient is not optimized prior to surgery, and the worst respiratory arrest has also been reported. So, respiratory arrest, right? Okay. So, what about the cardiovascular complication? Now, cardiovascular complications, blood pressure fluctuation may be seen in these patients. Risk of development of myocardial ischemia, myocardial infarction has been seen in these patients. So, cardiovascular complications, the hemodynamic or blood pressure fluctuation has been seen throughout the perioperative period in these patients. Then risk of developing myocardial ischemia, Now, these patients are at risk of developing the rhythm disorders as well, particularly atrial fibrillation. So, atrial fibrillation, right? Risk of developing atrial fibrillation. Then congestive heart failure, then congestive heart disease. Then the association of stroke has been also seen. The risk of stroke has also been seen in patient with OSA, right, in perioperative period. Now, apart from the respiratory and cardiovascular, the other system which may be, which can, in which the complication can result is kidney. Now, incidence of acute renal failure has also been seen in these patients. So, in others, I would write your acute renal failure, then the increased incidence of ICU admission, increased incidence because of all these complications, incidence of ICU admission, then and all the ICU related complications of ICU admission can happen like infection, etc. Then prolonged hospital stay, and all the complication related to prolonged hospital stay. The association of mortality in patient with OSA coming for surgery has not been established, right? That whether there is an association of high mortality or not, but definitely these complications all would increase the morbidity and mortality in our patients, right? So these are the complications that we have to look for. But there are strategies, there are ways, there are things which we can do to optimize and prevent these complications from happening. So when a patient comes to you, how do you assess? Most of the society nowadays recommend that when any patient coming to you for pre-anesthetic evaluation, we should, even if they are not a diagnosed case of OSA, we should ask the sleep related questions. Specifically, we should ask the sleep related questions to identify the patient who has not been diagnosed with OSA and has OSA. So some sleep related questions, some few questions which I will talk about can give us a clue, and then we can put a questionnaire. There are validated questionnaire which can be filled by the patient and which can help us in making a diagnosis that patient is associated with obstructive sleep apnea. And then we can take all the precautions and all the strategies we can practice to minimize the risk in these patients. So it is suggested making obstructive sleep apnea screening part of routine pre-anesthetic evaluation, part of standard pre-anesthetic evaluation. So how do we do it? By using sleep focused history and physical examination, right? Or we can simply ask all the patient to fill the questionnaire, or using using questionnaire which can be used for screening of patient with OSA, right? So this is what is suggested by most of the society, whether it's an American Society of Anesthesiologists or European Society of Anesthesiologists and Sleep Medicine. Everyone suggests that make the OSA screening part of your pre-anesthetic evaluation, your standard pre-anesthetic evaluation. Ask specific sleep related questions, and you can use in your patient the various questionnaire which we use for screening in OSA, in suspected OSA patients, right? So to understand what questions we need to ask, we need to know the symptoms and physical signs which would suggest that patient may be a patient with suspect, and patient may have association of obstructive sleep apnea. So what are the symptoms of obstructive sleep apnea? So symptoms of obstructive sleep apnea. Now these patients, if you ask the patient that do you have a proper sleep at night, or you have multiple awakenings, what is your, let's say, what do you feel during daytime? There is an increased incidence of daytime sleepiness in you. So increased daytime sleepiness, non-restorative sleep, or even after awakening patient is fatigued, right? Then patient and the relatives may complain, especially if you ask the relatives, that patient has a loud snoring. Then number of times the multiple awakenings at the night. If you suspect, you can ask the partner that does the patient has multiple awakenings at night. Okay, then awakening with respiratory distress. Patient may complain that he has a choking or a gasping reflex during sleep, and which made him suddenly awake. So awakening with choking or gasping. Then nocturnal restlessness. Patient will say he doesn't have a good sleep at night. He's restless at night. May not awakening may be seen, but because of the obstruction of the upper airway, then the patient doesn't have a sound sleep. Then insomnia, irritation. Patient doesn't have a good sleep at all. Patient sleep time is very less. Then lack of concentration in day. If it is in children, then their school performance may be less, may not be up to mark. Then cognitive deficit, they have memory deficit because of this sleep disorder. Then change in mood, morning headaches after awakening. Then strange dream, and in children sometimes nocturia may be present. So these are the symptoms which would suggest towards obstructive sleep apnea, right? What are the physical findings, or when we examine these patients? Well, especially during airway evaluation, there would be a lot of features which can suggest that patient may have association of obstructive sleep apnea. If their oral cavity seems too crowded, they are a higher Mallampati grade, right? So narrow or crowded oropharynx, Mallampati 3 or 4, or patient has a large tongue or tonsillar enlargement, narrow palate, all this predisposed to obstructive sleep apnea. Obstructive sleep apnea is happening due to the upper air, let's say collapse of the upper airway. It is happening basically due to the collapse of the upper airway. So all this would contribute in the collapse of the upper airway when the tone is decreased, and which can happen during sleep, which can happen during anesthesia. Then association of obesity. I mean, a huge number of obese patients are associated with obstructive sleep apnea. As already I mentioned, that though overall the incidence by ISD is calculated is less, but in at-risk population, the incidence, the prevalence may be very high. Then patient may have a large neck circumference, more than 17 inches in male and more than 16 inches in female. A thick neck, again, point towards association of OSA. Then craniofacial abnormalities. Patient with retrognathia, etc., they can also be associated with OSA. Okay. Then what are the associated comorbidities with OSA that we need to look particularly in patient with a known case of OSA, or in patient with a newly diagnosed OSA? Now, systemic hypertension, cardiovascular disease like heart failure, now cerebrovascular disease like stroke and TIA, dysarrhythmias, especially atrial fibrillation, pulmonary hypertension may be associated, and if patient has a pulmonary hypertension, the baseline pulmonary hypertension, then definitely we need to modify our strategies during anesthesia. Then core pulmonary, association of core pulmonary, then end-stage kidney disease, then type 2 diabetic mellitus, chronic lung disease. All these are the associated condition with comorbidities with OSA. In pregnancy also, in let's say patient with a very high BMI, the incidence of OSA, the association of OSA has been seen. Then in patient with acromegaly, hypothyroid patient, what other things can be associated with OSA? Gastrointestinal reflux. If patient has a gastrointestinal reflux, the incidence would increase in patient with OSA. Then secondary polycythemia, floppy eyelid syndrome, polycystic ovarian syndrome, Parkinson disease, Marfan or Ehlers-Danlos syndrome, sleep-related bruxism, like the bruxism, the gritting of the teeth, then fibromyalgia, that is the non-specific body ache. All these are associated conditions. This is an exhaustive list of all associated conditions which may be associated in patient with obstructive sleep apnea, right? And there are some of the condition which we need to rule out, because if patient is associated with the cardiac conditions, obstructive sleep apnea patient, the risk of complication further increases, and definitely we need expert evaluation prior to surgery. We need to optimize the patient to fullest to minimize these risks. Okay. Now, whenever we examine a patient with OSA, then the huge number, the OSA itself and huge number of other features which can make the intubation difficult may be associated in patient. So this is again all the factors which point towards difficult intubation. So patient having more than one factor of difficult intubation, patient can have association of difficult airway, and we need to take all the precautions to prevent any airway mishaps in these patients, right? So patient having history of prior difficult intubation, which may be in patient who already had a surgical anesthesia exposure previously, we need to ask that any prior difficult intubation. Then interincisor gap less than 4 centimeter, then thyromental distance less than 6 centimeter, sternomental less than 12 centimeter, head and neck extension less than 30° from neutral, Mallampati classification 3 and 4, inadequate mandibular protrusion, and neck circumference more than 40 centimeter, lack of submental compliance. All this makes the intubation difficult, and more than one factors may be present in patient with obstructive sleep apnea. And there are patients with obstructive sleep apnea who may not have any of these factors, but they are a diagnosed case of OSA. So it's a possibility, but whenever we have a patient of suspected or known OSA, we need to rule out all the points which points towards the difficult intubation, right? Okay, then let us now, after discussing the symptoms, the physical findings, the associated condition, right, we need to know our approach in patient with known OSA and in patient with suspected OSA. So in patient with known OSA, what are the things that we have to take care of? In patient with known OSA, simply we need to see what is the control of the disease at present, what are the therapies the patient is on, and we need to advise the patient that if the patient is on the positive airway pressure therapies like CPAP or BiPAP, or any airway appliances or oral appliances, patient is on the therapy of any oral appliances, to bring that device to the operating to the hospital, right? So we need, for patient with known OSA, we need to assess the severity. So assessment of severity, right? Then we need to see the adequacy of management. Adequacy of management, what is the things, how the patient is managed, and we need to see the treatment of OSA. What are the OSA therapies the patient is on? So patient may be on positive airway pressure therapy, that is on CPAP or BiPAP therapy. Patient may be on oral appliances. Patient may be on hypoglossal nerve stimulation device, hypoglossal nerve stimulation device. These are the various treatment of OSA. So patient should be instructed, so I am writing in red, patient should be instructed to bring any of the therapies the patient is on to the hospital when they are coming, because we would need to use them in perioperative period. So patient should be advised, should be instructed to bring these equipment, instructed to bring the equipment, right? So this is what we have to do in patient with known OSA. We have to see the severity of the condition at present. We have to see the adequacy of the management, what are the management things which are being done, and whatever is the management and the appliances the patient is on, we need to know about it, and we should instruct the patient to bring it to the hospital.